This is a surgical video showing phacoemulsification of a Brunescent cataract. The speed of this video is increased to 2 times the normal speed. So the side port and normal 2.4 millimeter corneal incision is first created. This is followed by injecting viscoelastic in the anterior chamber. In this case, because the red reflex is still visible, so vision blue wasn't used to stain the anterior capsule. But otherwise, using a vision blue to stain the anterior capsule will make this step of the procedure much easier. Capsulorhexis forceps is used to create a capsulorhexis. This is then followed by hydrodissection to free up the epinucleus, so to facilitate the emulsification of this dense nucleus. So the nucleus is now mobilized. Next is the phacoemulsification of the cataract. The soft cortex or the epinucleus is first emulsified. Then the central trench is created. This is a technique. The technique used in this video is called stop and chop. The width of the trench has to be at least as wide as the phaco tip with the sleeve, so that the sleeve, the phaco tip is not being blocked by this nucleus. The key here is to sculpt as deep as possible in order to facilitate the cracking of this nucleus into half to facilitate the subsequent emulsification of the nucleus. So once you are emulsifying the posterior part of the nucleus, make sure the focus is adjusted in order to have a good view of the posterior aspect of the nucleus, and also to be able to judge the depth of the trench properly. Once the depth is is deep enough, then we'll try to crack the nucleus. In this case, as you can see, the central part of the nucleus is still adhering together. It's very rubbery, so the decision is to continue to do deeper sculpting. The initial part was actually performed by my trainees, and now I'm taking over to perform the subsequent surgery. So once the nucleus is cracked into half, it will be quite easy to hold the nucleus out to the center part of the eye for subsequent emulsification of the nucleus. As you can see, the nucleus is actually not that hard as compared to the epinucleus. In this Brunescent type of cataract, a lot of time the epinucleus is very rubbery, is taking more, it will take more time to emulsify as compared to the nucleus. Sometimes the nucleus is even easier to be emulsified, as you can see here. Now I'm trying to crack the nucleus, chop the nucleus. You can see the nucleus is not as brown as compared to the epinucleus. See, the epinucleus is really deep brown in color. So this is being done piece by piece manner. So the procedure is the same whether it is a very hard dense cataract or a soft cataract. Only different is there will be more energy used in emulsify a denser cataract, and also the time used is much longer, because every single piece of this nucleus or epinucleus material got to be emulsified in order to be aspirated. So you have to be patient in performing this kind of surgery. Once you find that the anterior chamber do not have any more viscoelastic, then more viscoelastic is injected to protect the endothelium. So continue in cracking, chopping off the other half of the nucleus, and also to emulsify it with the phaco tip. So in a gradual fashions, now we left about 40% of the nucleus and epinucleus, and this is a time where we have to be a bit more careful to monitor, make sure the posterior capsule is not coming forward, make sure the anterior chamber is well maintained with the machines. So at times when come to the last quadrant like this, I'm going to reduce my vacuum to a lower vacuum. My initial vacuum can go as high as 500 millimeter mercury. When come to doing this epinucleus, I can reduce the vacuum to about 250 millimeter mercury. Okay. So now the epinucleus and the nucleus part of the cataract is being removed. The next step is to perform the IA to remove the cortex at the capsular bag. So I'm using a curved IA tip. So be also very careful in doing this procedure, because sometimes this is the time, if you are not careful, you can actually rupture the posterior capsule. Viscoelastic is then injected before implantation of the lens. This is a 3-piece preloaded Kowa lens that go in easily without manipulating tube and turn of the haptics. It come out nicely and very easy to implant this 3-piece lens into the bag. Viscoelastic is then removed with the IA. The wound is then secured by hydration of the wound, and then the posterior part of the viscoelastic is then flushed out with the balanced solution BSS, and through the side port again the lens is being pushed down to stay at the posterior capsule, and then the wound is secure. Wound is checked, and that's the end of the surgery. Thank you for your viewing.